Please do the video call.
No, it's okay.
Yeah.
Okay, we are live.
Yeah, good evening, everyone. I welcome all of you to this masterclass. So this is one of the toughest topics to discuss, that is comparison or differentiation between NICS and PGT-A. So knowing about PGT-A itself is a big thing for a clinician. So over this, we are talking about which is better compared to PGT-A and NICS. As clinicians and as we have our regular embryologists, we all depend on morphology of the embryos to choose and do the embryo transfer. So we are going to the next level to increase the implantation rates, to transfer euploid embryos, to reduce multiple pregnancies, to have singleton pregnancies by reducing the number of embryos transferred, and also to reduce recurrent miscarriages or recurrent implantation failures. So this is a very niche topic, and I think it is the need of the hour because many patients are older now and they ask how confident we are in telling about the embryo that we are transferring is euploid. So this class will give you a practical aspect as to what is really doable and what is not worth doing and making the patient spend unnecessarily. So over to you, sir. You can take over.
Yeah. So just stay unmuted, okay? You can see the screen, no? Yeah. You can see the screen, right, Shilpa madam? Yes or no?
Yes.
Okay, fine. See, so we'll be discussing PGT-A versus NICS, and that is basically your pre-implantation genetic testing, mainly for aneuploidies. Okay, and you are going to compare it to NICS, which is basically non-invasive chromosomal study. Okay, now both of them are basically done for testing of genetic factors of embryo. All right, in this entire thing, please remember one thing: science has proven it now without a doubt that if you are able to place a euploid embryo within the endometrium, if this embryo within the embryo endometrium is a euploid embryo, okay, then the crosstalk which it has with the endometrium, okay, itself, okay, is the best way to achieve implantation. As a result of which, see, all of us were euploid embryos. All right, remember that, which is why we got implanted nicely, delivered, and all these things. And this euploid embryo is basically going to come from a good egg. Okay, this has been proven. This is absolutely proven in science without any doubt, which is why people are now trying to focus on genetic testing, especially because the incidence of doing single embryo transfers has gone up. Okay, highly. All right. Second, age of the female partners has gone up to more than 37 years. 90% of the patients, at least in good clinics, the non-marketing ones, want self cycles. Okay. And when they want self cycles, they really want self cycles. Okay. All this actually donor and all that janjat of cheating, shooting and all is only in India, because in other countries, majority of them would also be wanting a DNA matching. All right, especially if you have had the experience of treating international patients, you will know that you are supposed to submit a DNA matching letter. So when a DNA matching is to be done, obviously you want to do a PGT-A for that patient, right? Then comes in the case of recurrent IVF failures, okay, where we think that the embryo was a great morphological embryo. That means the embryo was grade 4AA, excellent morphology as far as the classification, but even excellent morphology embryo can be aneuploid. All right. Even an embryo which crosses all the annotations of time-lapse imaging. So if you have a time-lapse inside your system, if the time-lapse annotations are absolutely perfect, it can still be an aneuploid embryo. So recurrent IVF failures, recurrent abortions in the past of unknown origins, chronic, any form of immunological problems which you are suspecting in the patient, and any other known genetic disorders okay, are basically your primary indications for actually opting for some form or the other of genetic testing inside these embryos. All right. Now, when you actually test for the genetic testing and when you opt for genetic testing, that is when you actually need to understand what is the difference between PGT-A and what is the difference between NICS. All right. Just remember the word itself is, going to be self-explanatory. Non-invasive, so it doesn't invade. Okay, so basically you have a culture droplet, and inside this culture droplet you are growing a blastocyst embryo. Now usually after the stage of day 3, okay, when it becomes a morula, this embryo, the speed at which it grows, it lets out a lot of DNA through its cells. This is just standard exsanguinated DNA which happens to every human cell. This DNA is exsanguinated either in the form of fractions, okay, or in the form of complete strands, or in the form of half strands, or it is just exsanguinated as some part genes. All right. Now, what you are supposed to be doing is that at culture time between 108 to 114 hours, usually you want to pick up approximately 20 microliter of this culture fluid. Okay, you want to pick up 20 microliter of this culture fluid, send it in a test tube, well preserved. So this test tube is going to contain preservative plus this entire fluid, and this fluid is then going to be subjected to genetic study. And most of the times, this genetic study, I'll come to this genetic study, it's something which is done on a platform called NGS, which simply stands for Next Generation Sequencing. Okay, that is the platform which is used. It is based on a kit. All right. Compared to that, what are you going to do in a PGT-A is that, let's say if this is your blastocyst embryo, which is growing here, okay, and you want to take a biopsy, basically, the blastocyst embryo is going to consist of an inner cell mass and a trophectoderm. So PGT-A is also referred to as trophectoderm biopsy. So what you are going to do is you have a zona which is surrounding this. All right. When you apply laser impulse over the zona, so let's say I have lasered this much part of the zona, it is always going to be done away from the inner cell mass. So when I laser this particular part, see, when I laser this, let me just cut this off and let me just show you what happens. See, when I've lasered it, it becomes something like this. Okay. And you have the trophectoderm cells. A part of the trophectoderm cells would just pop out, and you use a special biopsy pipette in order to then apply the fresh laser through this. So approximately 4 to 6 cells. Okay, 4 to 6 of these cells are going to come out. Now you can easily argue 4 to 6 cells, how will they be a representation of the entire embryo? Remember, at this stage of blastocyst, these cells are usually going to be totipotent cells. Okay, so that means they will give you some identification of that. The only defect is that these are the guys which are actually going to go and form the placenta. The embryo is going to form from the inner cell mass, and you can't really study the inner cell mass in PGT-A. You can't do that, but the advantage is it is a totipotent cell. The advantage is in NICS is that this fluid which you get has DNA coming from the trophectoderm as well as from the inner cell mass, so you can have a more complete picture. All right. Now, even these cells which are taken are then going to go through a genetic study on next generation sequencing. All right. Just remember, after you have remembered all these things, okay, though I've tried to cover it quickly, just remember that with PGT-A, you have a little advantage. The accuracy of PGT-A is approximately 99%. The accuracy here of NICS on good kits is approximately 90%. This 90% is also very recent. For a little while back, actually, the genetic study was not so easy because the amplification kits were not so commonly available and they were not very good. But the amplification kits which are now available are fantastic. So it is very, very good. There is only one specific condition where PGT-A would be much better than NICS, and that is in cases when you have monogenic, that means monogene disorders. Okay, these monogene disorders are, let's say, something called as Duchenne muscular dystrophy, or you have special sickle cell variants you have special thalassemia variants. In all those situations, you need a specific gene probe, which is called as PGT-M. All right. That is for monogene defects. And for monogene defects, currently, definitely PGT-A is going to be the treatment of choice. Otherwise, the things which are important for you to understand is that this entire procedure of PGT-A requires you to be an expert embryologist. Okay, in order to take this biopsy without causing any form of damage to this embryo. Okay, with NICS, the thing is your culture condition. All right, your culture condition has to be superb. All right, if you have a poor culture condition, then this is going to be poor. Then the genetic amplification is also going to be very, very poor in this entire situation. All right. Also, please remember that when you are doing NICS, you should do a day 3 media change. So your media should change on day 3 because it flushes out all the abnormal structures. And then from morula, when this embryo goes from morula to blastocyst, that is when this DNA is let out the best, which is why you should have a day 3 media change as far as NICS is concerned. All right. Also remember one more thing, guys, as far as the cost is concerned, PGT-A and NICS is really based on how you negotiate. Okay, the average cost is going to be approximately 10,000 per embryo, where also you will make some profit. And let's say if you are lousy as far as bargaining is concerned, some people may even take 14,000 rupees per embryo, and you will not be able to make so much profit out of all these things. But otherwise, please remember, this is the technical aspect of it. If I come to the clinical aspect of it, it is absolutely popular. Okay, it is like, Arey Bapre, why did I talk so many things when the clinical aspect is so easy? I hope people don't come to my house and slap me at the end of it when the end point, which we are concerned about, is so easy. Okay, irrespective of whatever study you do, end point is simple. Okay, you are going to be dividing it into 3 phases. One is euploid. Second is aneuploid. Okay, simple. Euploid matlab go ahead with transfer, aneuploid matlab don't transfer. Third is the confusion, mosaic. Okay, so in mosaicism, you need to look at something called as mitoscores. You need to look at it in euploid also, but in mosaicism, you need to look at mitoscores, which gives rise to low mosaic and high mosaic. High mosaic, I don't transfer. Low mosaic, I transfer bindas. Low mosaic is embryo in whom, so basically euploid embryo is the embryo as far as any embryo which has less than 30% defects. The aneuploid is more than 70% defects. Mosaic is between 30 to 70. Low mosaic is between 30 to 40. High mosaic is between 40 to 70. These two people go ahead and transfer, good success rates. If the report is high mosaic and aneuploid, do not apply your head. Do not transfer. Very, very simple. No confusion. Probably I will take a good masterclass to probably explain to everyone how to do the mitoscoring and how to study it, and how to amplify the genes, what kit to use, how to use the kit, where to order the kit from, which country is making the kit, can we make it in India, what is the cost of the equipment, should you buy it, should you rent it, all those things I will take a separate masterclass. I don't think it's even the scope of gynecology, but I love that subject, so I have digged little deep inside it. Okay, but with that I conclude, and maybe 2 or 3 questions from Shilpa madam and I'll answer.
Yeah, you told about sorry, 1 second. So what is the rate of aneuploidy in 4A blastocyst? You said even if it is a 4A blastocyst, there will be still aneuploidy.
15-20%, madam.
Okay. So have you tried combining these 2 methods, the PGT-A and because they seem to have their own advantages?
Yeah, we can actually do that, but then I don't think PGT-A alone is good. If you want to just test something, just do PGT-A. If you're taking a biopsy only, then why send the fluid? Yeah.
No, but that is like both from inner cell mass and the
No, but I'll tell you one advantage of PGT-A. PGT-A you can do even on day 6. NICS you can't really do on day 6. Okay. NICS, that time window is important. Otherwise, the amplification won't occur, madam, because then the blastocyst will undergo contractions. So, yeah.
So what is the problem with PGT-A? I mean, I read some papers saying that there is increased risk of preeclampsia.
No, I'll tell you the problem. The problem is you are taking a biopsy at, let's say, 115 hours when the report turns out to be high mosaic. Okay, when you do then the embryo will undergo freezing, then it will undergo thawing, and then you will do the transfer. Correct. So what problem happens is when you have a PGT-A embryo, this embryo has a propensity to autocorrect.
Hmm.
When this embryo autocorrects and you tell somebody, "Arey, tumhara to high mosaic embryo, I can't transfer." Okay, and if the patient comes to you and tells you, "Arey, par please dal do mere paas mein yahi embryo," and then when they have a healthy child, no, they will whack you. Okay, "Arey, you are telling don't transfer. Now the child is healthy." So there is this principle of autocorrection, which is why if you overuse PGT-A, I mean, if you say that I will do PGT-A in all people, like how it is done in United States of America, it's basically done in United States because they want to collect genetic data of the patients. बाकी कुछ खास logic नहीं है. But 4-5 गोरिया लोग will come to Indian conferences and say do it. Then all of us will start doing it. Understanding? But they have a different mechanism. If you do it in all patients, it is not good. If you select your patients based on the indications as per Indian ART law and do it, then it is very good.
So what about maternal contamination in NICS? I mean, is it a big problem?
Not if you change the media and keep culture conditions good. I told you, culture condition is very important. If you don't have good culture condition, you are finished.
Mhm. So what is chimerism? I mean, I just read it as a
So,
thing. Use it, okay, leave it. I mean, so have you seen that it increases pregnancy rates by doing all this PGT-A and NICS?
it increases pregnancy rates when you are putting single embryo transfers. 100% it does.
In your experience, you have.
Yeah, 100%. If you want to do single embryo transfers, you should do PGT-A because you want to put euploid embryo. No, first attempt only you should put euploid embryo. Patient will become pregnant.
So you have moved to single embryo transfers now?
Not in all, madam, but around 30%. Or yes.
Okay. Yeah, I think I'm done. I mean, this is all I could read. Yeah. So,
Right?
no, I mean, I didn't
Okay.
have.
So I'll just answer because you asked. I mean, I ignored it because remember, see, chimerism is something no where a single cell or basically a single tissue, okay, would have two sets of DNA, two different sets of DNA. Understanding that will usually happen when there is a genetic defect or something like that in the embryo. Okay, that embryo will test out as negative only. So you need not worry about that, madam. Which is why I said to be ignored.
So in this NICS, you will have to culture all these embryos separately, right? Because
Yeah,
you're taking.
no co-culture. It has to be cultured separately.
Okay. Whereas in PGT-A, I mean, how much time does it actually take to take one embryo biopsy? To take those 4 to 6 cells, how much time do you take? It will take like say a minute.
5-10 seconds.
That's all.
Because once the embryo, what we do is no, one day before we are going to hatch everybody.
Oh.
Okay, we'll apply that laser pulse over the embryo one day before only, madam. You will come to know when cavity is developing, which will develop blastocyst. No, so that pulse you will apply before that only. It will be just 2 pulses which you apply. Okay. So when you apply those 2 pulses on the next day, when you are going for taking that biopsy, all those embryos, trophectoderm cells will be out like a puchku. Okay. And you just have to apply there is a pipette in order to collect this. It is something called as a biopsy pipette. Okay. And in that biopsy pipette, you just have to fire the laser. Nothing happens. It's beautiful.
Do you do this laser? Do you shoot it like for all embryos?
Yeah, I do it on laser only.
No, not for PGT-A. I mean, even before transferring, like if you are
No,
not.
no, no. No, no, no. No, no, no.
Okay. Yeah, thank you. Thank you so much.
Okay, thank you.
I will just check the chat box. I'm sorry. I will just check. So any advantage of transferring day 3 embryo in either fresh or frozen cycle? Or is it same as day 5 in case of genetic modulation? You don't do day 3, right?
Nobody does day 3.
Which lab would you recommend for NICS?
No, that's a commercial question. I don't recommend.
Criteria for performing PGT as per ART law also apply to
Of
NICS?
course, it is not for PGT-A. It is for genetic testing.
if we do pooling of embryo 1 in 1 cycle for low AMH freeze all, then when to do biopsy?
Individual biopsy before freezing.
I have transferred 2A embryo PGT-A normal in 42 years, patient having previously 4 IVF failure, then what would be the probable reason even after doing ERA test failed?
No, that is because in patients at age 42, no matter what you transfer, even if you sit inside the uterus and transfer the embryo, success rate of implantation is 25%. No, so the age is the factor. It is not the PGTA or ERA. Any which ways, ERA is not important at age more than 37. So doing ERA beyond, and any which ways, ERA is bakwas for Indian women. Okay, it is a correlation which is done with European genes, whose epigenetic factors and modulation are diet dependent. They don't follow the glycosylation patterns of Indian genes. So you can't really apply ERA to Indian people blanketly because 2 people in Spain decided it is very good. ठीक है, ऐसा नहीं होता है.
Okay, thank you.
Yeah.